dear professors and colleagues. Tonight, we are honored to have Professor Ricky Harrell with us. Firstly, I will introduce our precious guest who actually doesn't need introduction, but I just want to be polite and, observe the formalities. So Dr. Harrell is the Program Director Emeritus in Georgia School of Orthodontics. He also is an adjunctive faculty member in Center for Translational Orthodontic Research Residency Program in Hoboken, Jersey, and also adjunct faculty member in Emory University Oral and Maxillofacial Surgery Residency Program. Dr. Harrell, thank you very much for accepting our invitation and joining us tonight. We are impatiently waiting to hear your lecture about the new emerging technologies in orthodontics. So we are all ears and the stage is yours.
Yeah, as soon as we get this slide up, we'll be going here.
You need this, right?
That one, yeah. Yeah. Okay. Raise it up. Presentation mode. You guys see it okay?
Okay, let me see.
Solar, everything good?
Yes, I can see.
Yeah,
Yes,
okay.
everything's okay.
All right, well, welcome everybody. Thank you for taking the time to sit in on this. I apologize for the technology issues. That's always stressful on your first go around. But today we're going to talk about some recent advances and emerging technologies in orthodontics. I would caution you guys that I'm going to show you what the technology is. I'm also going to show you some pitfalls of this technology as well. So don't think because something's new and great that it's going to work within your practice. So here are some areas that we're going to cover. Bracket design, I subtitled this Promises Made, Promises Unkept. And I'll show you a case example of why you cannot always buy into the seller's claims about their product. We'll look at some computerized brackets, robotically produced arch wires, such as those used in a technique called SureSmile. We'll look at a brand new approach to orthodontics called the BRIUS system. We'll take a look at 3D printed devices and appliances, temporary anchorage devices, which have been around for about a decade, computerized cephalometric tracing, 3D scanning, virtual treatment plans, and 3D and 2D virtual surgical planning, as well as virtual visits, remote imaging. And the question is every piece of technology useful? Some is, some not so much. So it is up to the practitioner to evaluate, to read the literature, and then decide if the technology can be incorporated into his or her treatment regimens. So I will tell you the two biggest shifts in technology when I came on board as a young orthodontist some 40 years ago. We went from pure edgewise to pre-adjusted, pre-angulated, and pre-torqued brackets. In other words, the straight wire system came into its existence, actually when I was doing my residency. The second big innovation for orthodontics was the NiTi, or nickel titanium alloy arch wires. They were a game changer. So if you're an orthodontist, you have it easy these days compared to what we used to have to deal with. And then we've had the reintroduction of self-ligating appliances. And unfortunately, we're going to look at some of the impacts of this appliances that they've had on orthodontics as we know it. All of a sudden, everything went from some extractions to completely non-extraction because of the appliance. Well, the self-ligating appliances actually were a reintroduction of the self-ligating appliance. The first one was introduced to orthodontics in 1933 with what was called the Boyd brand bracket. We did not have acid etch and composite materials in 1933. In 1951, a second self-ligating bracket was introduced by Dr. William Ford. And the first one that had commercial success was introduced in 1971, and then another one came on board in 1980s. There's a bracket called the speed bracket that was introduced in the 1970s by G.H. Hansen, who went on to start the G&H Archwire Company. But what really caught the attention of the public was the Damon system. And here it is. And you can see, let me get my, excuse me just a second here. Whoops, let me back up some. Sorry about that. Well, every time I try and get my laser pointer. As you can see circled there, there's a lower incisor metal bracket circled with the arch wire end. Notice there are two stops, crimpable stops, one on each side of that bracket. Does anybody know why those stops need to be there? These arch wires will actually migrate around the mouth if you do not have stops on the wire, because there's so little friction between the wire and the bracket interface. Well, I'm going to show you an x-ray that's going to make you think twice about ever putting in an arch wire without stops. And in this particular child, can everybody see? Whoops. Can everybody see by the red arrow?
Yes.
This is an arch wire up into the child's brain. What happened was a dental assistant put the arch wire in, didn't put crimpable stops. The arch wire itself started migrating as this child was chewing, because the arch wires will move. It entered the soft tissue distal to the lower left second molar, migrated up the lingual surface of the ramus, right through foramen ovale and into the child's temporal lobe. And the child started having seizures and could no longer speak as he once spoke. He was bilingual and he quit speaking English, started speaking Spanish, and then his Spanish became unintelligible. He was taken to an urgent care center. They didn't take a film. They thought he had an infection of the parotid gland, gave him some antibiotics. He was later taken to a regional trauma center where they actually did this CT scan, and somebody said, "Oh, here's the arch wire." And it migrated all the way up into his brain. So it's very important that you put stops on here. What are some of the claims of the self-ligating systems? Number one, their efficiency and initial alignment. That's one of the things that may be true about them. It claimed that they had superior or less bond failure rate. One of the problems is plaque retention and periodontal health around these brackets. So the only advantages from a systematic review of self-ligating brackets that was noted was a slightly shortened chair time and a little bit less incisor proclination, because you get a lot of bicuspid expansion, especially in the lower arch with this system. So I'm going to show you a case in just a second of why you have to be very careful with thinking that you can treat every case non-extraction with these brackets. So what are some of the disadvantages though? Increased costs, they're very expensive. They have a larger profile because they have to have a door that can open and close. They have a little more occlusal interference because they are thicker. The bracket itself, not so much the bonding, but the bracket itself is prone to breakage because it has a moving part. It's difficult to express our first, second, and third order tooth movements, and sometimes the brackets become inoperable when there is calculus formation around them. So it looks great on paper and they work. I've treated many cases with self-ligating brackets, but you can't just throw away your diagnosis because of the appliance system. So the bracket system has affected treatment planning and execution. All of a sudden, extraction cases become non-extraction cases. So let's look at one. Here's a little girl. She was 17. This was at the University of Colorado. You can see she's got a lot of crowding. Let's see if I can get these guys a little bit out of the way here. You can see in her lower arch, it's kind of parabolic shaped with a lot of crowding. Just a second here. Okay, here we go. Here's her Panorex. Here's her cephalometric numbers, and her lower incisors were in about the right place. But I want everybody to look at how her incisors are positioned here. So she was treated with self-ligating brackets, and here they are. And look at what's happening to her lips. Can everybody see the increased lip incompetency that she has? The arches look good. Here's her pan. Let's look at her ceph. Can you all see changes in incisor angulation? Anybody? Salar, can you see it?
Yeah. I'm looking in.
Yes.
Yeah.
We
So
can
the inner,
see a lot of protrusion in lower incisors.
yes. So the inner incisal angle is at about 90 degrees or less than 90, which is entirely inappropriate. What was the solution? And you can see the before and after there. And you can see the incisor proclination, especially here in the lower arch. So the solution to this was this case was given to me as the clinical director to bail out. So I kept the brackets on, took out 4 bicuspids, and look at her profile now. And you can see the arches look good, space is closed. Her incisors have returned to approximately the initial angulation. And here was her final photos when we debonded her. And if you noticed, I finished the case with the self-ligating brackets. So the bracket is not the driver of the treatment. It's the diagnosis that you have. And the incisors have returned almost to their pre-treatment positioning cephalometrically. And you can see the profile before. In the middle is at the peak of non-extraction, and to the lower right is the final profile. So if we look at the E line from the tip of the nose to the tip of the chin, look at the lower lip in the middle position. And the lower lip in the initial is mostly behind. And you can see on the final that her profile meets norms pretty well. Here she was 2 years later. So it's not the bracket that should be driving the treatment. It is the diagnosis and treatment plan. So self-ligating brackets are here to stay in the United States. There are a lot of practices that now advertise we are non-extraction. And I think that's a bad move on their parts. Computer design brackets. Here's some insignia by the Ormco company on the bottom left. And on the bottom right is the incognito bracket system. They used to be out-of-the-box brackets. When I was in school, I treated a couple of lingual cases when the appliances came out. But the reality is now they are computer printed, 3D printed, so that they fit the lingual surface perfectly. They're also very expensive. Here's another company that's making computer design brackets. So they take into account in and out, tip, and torque for the dentition. Here's some 3D designed lingual appliances on the left, and this is what they look like on the right-hand side of the screen, when they're attached to the teeth. So we're printing brackets now. Each one is unique and it's custom fitted to the appropriate tooth. Here's the thing that you should be aware of if you elect to use these in your practice. With traditional brackets, you buy, say, 30 cases at a time. And if you lose a bracket, a patient loses a bracket, you can go and pick a bracket out of your supply. With these computer printed brackets, you have to contact the manufacturer, have another bracket made, which is expensive. To do a single bracket, it's very expensive. And then they have to send it to you. So you lose time in treatment if the bracket is lost. Okay? When we start using lingual appliances, we've had to switch to arch wire forms. Typically, we have a tapered, broad, and an ovoid. And here they have just lower small, lower medium, lower large. And we call these mushroom arch wires because it looks like a mushroom a little bit with the rounded part of the front. You have to do, this is the canine offset right here. So the arch wires have to be different. So if you're going to be using lingual appliances, you have to have a special set of arch wires as well as a special set of tools in order to use them. So here's a picture of somebody, it was an advertisement I took off of a website. And to me as an orthodontist, I'm seeing gingival recession both before and more after, especially in the upper left bicuspid there. And remember, soft tissue recession always follows bone loss. So a lot of times when we expand these teeth to make these big broad arches, we're actually moving the teeth out of cortical bone. Here's an advertisement for a system in the US, 30% broader than other broad arch wires on the market. And when you expand, especially the lower arch, you run into relapse problems. So let's take a look at that. If we expand our canines, do they constrict after the removal of the appliances? The answer to that, yes, they do. What's the evidence? I want you to look at the dates on these. 1944, 1989, 1973. 1974, 1961, 1949. In other words, we've known that you cannot expand the lower canines in most cases more than about 1.5 millimeters without increasing the potential for relapse. Well, the reality is that the Damon appliance generally will increase the inner canine width in the lower arch about 6 millimeters. So we have to be careful about jumping on the non-extraction at all costs bandwagon because there is an appliance out there that will accommodate that. So they did a bunch of studies to see if, if bicuspid extraction leads to dished in faces and things of that nature. And the answer is no, it doesn't, except when it's inappropriately diagnosed. What else? Bracket prescriptions, 3D scans. There's a company called SureSmile that uses any bracket, but they do computerized arch wires for finishing. And it's supposed to give you a superior product. So this is pretty much what it looks like. When you send in your case, you do a CBCT, and you can see the roots are not parallel. There's irregularity in the alignment of the crowns. On the right-hand side of the screen is what this case is supposed to look like once you get the SureSmile pre-bent arch wires in place. So that's some technology there. Robotically bent arch wires for Sure Smile. This is what it looks like. It's a robotic device that bends these wires in about 30 seconds. There's an orthodontic lab near where I lived in Georgia the last 7 years, and they have a machine that bends the Hawley bows for retainers in about 30 seconds. It's incredible to watch. So we have robots now doing computer designed arch wires. In the aligner arena, there's a company out there that can predict where the roots are going to end up if you send them the CBCT before you start your Invisalign therapy. So you can see with the non-extraction at the bottom, can you see all these roots that are out of the bone here? And if we look up top, this was an extraction-based case. And so it's possible to line the teeth up and keep the roots within bone. So these are all things we could not see 20 years ago, but they're becoming very apparent now. Now, if you think that you cannot move teeth out of bone with orthodontic appliances, look on the left-hand side. And you can see, you can visualize all the roots, and you can see where the teeth are actually placed on the right-hand side. All 6 of these anterior teeth are completely out of bone. And on the right-hand side, there's a cephalometric film, and you can see that the maxillary incisors out of the bone, the mandibular incisors are out of the bone. Here's another case that I've written an expert witness report. This is in a malpractice lawsuit. You can see that whoever was doing the orthodontics moved the central incisors completely out of the alveolus and into the palatal soft tissue, and the lower incisors have been moved out of bone. So if you buy into non-extraction at all cost, these are some of the things you're going to see if you bother to look at what you've actually done. What else here? This one's kind of a fun one. It's called the Brius system. And you have to 3D print an arch wire for it. It came into the marketplace in 2016, and the headquarters is in Texas. The company's advertisements say that they can significantly reduce time in treatment. There's not much research to validate the claims. The only clinical trial I could find was at State University of New York, Buffalo. And I talked to the program director at an educators meeting, and she said, it's kind of like Invisalign. You have to do a lot of refinements. So this is how they say how fast their appliances work. You can see here about a month, 3 months, 6 months, 7 months, 10 months. I find this a little hard to believe. I don't think it's valid research. That's entirely too short a time to be able to correct malocclusions in this tan color here. This is what the Brius appliance looks like. So the manufacturer creates all these little receptacles for this arch wire that are bonded to the teeth. And again, this is all computerized. And then you place in this big lingual arch with all of these attachments that fit around the attachments on the teeth, and they move teeth right to their final direct place. And with this, if you lose one of the brackets, or if this arch wire breaks, which it does, and one of the people that work there, I talked to him at a meeting, he said yes, because the chewing pressure on the NiTi wire eventually fatigues this wire. And so sometimes this arch wire up here will break, and you can still use it. It's just that one tooth doesn't move. So you have to order another lingual arch with all the attachments. Well, this is called the Brius system. It gained a little traction in the United States, but not very much. 3D printed appliances. We're now printing, we don't print the screw itself, but we are printing the framework for our palatal expanders. And you can see this is the template for it. Here is a W arch that was 3D printed. And you can see even the bands are 3D printed. The downside to the bands is they don't go all the way through the contact point. So you have less band in contact with the tooth surface. So these things are prone to dislodge a little bit. Here is a 3D printed Herbst appliance. And you can see how it fits over all the teeth, but it does not go through the contacts. And this is what it looks like in the real world. Okay, temporary anchorage devices. They've been around for 15 years. And hopefully all of you are familiar with them. I don't know what the background of this audience is as far as general dentistry versus orthodontists versus oral surgeons versus students. But typically there'll be a male head, in other words, something that's protrusive out of the tissue where you can connect springs, elastomeric modules, other arch wires, whatever you need. They're considered to be absolute anchorage. There should be no movement of the screw or to the dental unit to which that screw is attached. So you can either use what is called direct anchorage. And if you look down here, this is an application where we're going to close the space where a second deciduous molar had no replacement. This girl was missing 3 second bicuspids. And so you see in the upper arch, it's easy to close the space. We don't have a tad up here. In the lower arch, we have what's called direct anchorage. So we want to move this molar up to all the way through this extraction space. And you can see this is how the case ended up on the right-hand side. Before TADS, when you tried to do this, unless the patient was a great rubber band or elastic wearer, you would pull the midline around to the side of this big 10 millimeter space. And I know that for a fact because I've done it before. Here's what's called indirect anchorage. We have a TAD that's tied to a group of teeth that are all wired together. And then we can retract the anterior segment. That's what it looks like. And then on the right-hand side, you can see the segment is closed. A TAD-supported rapid palatal expander, or we call them MARPEs, M-A-R-P-E, mini screw assisted rapid palatal expansion. So this is on a 17-year-old that we couldn't get his suture to open with a conventional expander. We used a TAD expander, and then this is what his arch looked like on the right-hand side. And you don't even have to have the arms to the teeth for these to work. You need something to support the TAD, and you can make a template that fits up in the palate to screw it in, or you can temporarily bond legs, the little arms, to the bicuspids, screw it in, and then we just cut those arms off. You can see there was a little, let me back up here, I'm sorry. You can see the remnants of the arms right there where they cut those off. Okay, what about our imaging? The Dolphin imaging system has been around for a while, but they've made some significant improvements. We can manage our photos, our radiographic images. We can do treatment forecasting. In other words, what we call a visualized treatment objective. We can keep our patient records in Dolphin. We're going to talk about CBCTs and their implication. We see that all the time, not just in orthodontics, but also in oral surgery and restorative dentistry, as well as endodontics. We'll talk a little bit about 3D scanning, surgical planning with 3D imaging, which is now state of the art, and we'll look at that. And then we'll talk a little bit about remotely supervised patient visits. And that was kind of introduced into dentistry with the onset of COVID in the United States. And now virtual visits are a part of many practices in this country. Dolphin imaging came around in the mid-1980s, but that was the basic package. It's been wildly reformed now. It was originally used for just photographic and radiology imaging storage, and now it's much, much more. In the United States, 97% of the residency programs use this technology. 72% of oral and maxillofacial surgery residency programs use Dolphin, and 20% of pediatric dental residencies in the U.S. use Dolphin regularly. One of the things we can do in Dolphin is trace cephalometric films. This is the old school way of doing it. You had to have a pencil, a protractor, a view box, some tracing paper, and a cephalometric film. And then this is what it looked like when we were doing it. We would have to be pretty handy with a protractor, and we would measure things, and then you can see on the right where we write all the values in. Well, now it's much easier. This is it's called a composite 10 in Dolphin, and you can just click on any of the images and they will enlarge so you can study them closely. This is the cephalometric tracing program in Dolphin. And so you pick the cephalometric analysis that you want to use, and then you start putting dots, and you can see all the dots over here on the left. 2 ruler points to determine the verticality, orbitally, sella, nasion, soft tissue, glabella. But it gives you a list, and the computer actually talks to you while you're placing the cephalometric landmarks. And so you can see I've started to trace this ceph, and you can see these little red dots. So here's our sella nasion line. Here's our porion, infraorbital rim, or Frankfurt horizontal, soft tissue outline. We trace the teeth and the jaws in here, and then it immediately, within 2 seconds, spits out the cephalometric analysis with the values. And you can see all of these in red are something that you should be very concerned about in your treatment planning, because those are more than 3 standard deviations out from normal. So it will give you a beautifully printed ceph tracing and the cephalometric values in a matter of 2 or 3 minutes. What else? 3D scanning in orthodontics. Fortunately, we don't have to live in a world of alginate, polyether impression materials, plaster bins, model trimmers, and generally messy labs and clogged sinks. The dirtiest place in any dental office or dental school is the laboratory. So the introduction of scanning technology for model production is very positive, and we use it in many areas of orthodontics. And if you're inclined to produce a hard copy model, you can use a 3D printer and produce that hard copy model. So in the world of the Dolphin imaging system, they have a place where you can view the 3D images, as you can see here. I've just blown this up over here so you can see it. You can click on that, and it will bring you up the model. Now, which do you think patients prefer? Scanning on the left or taking an impression on the right? And what do your assistants prefer to deal with? Scans and computer screens, or alginate, plaster, dirty sinks, clogged sinks, etc.? And so here's the difference between a traditional orthodontic set of study models. Over here, from start to finish, this is about 2.5 hours of labor. On the other hand, you have about 30 minutes to get a 3D printed set of models. So time is money in dentistry. And if you can save time, that time will pay for the technology. And once it's paid for, it's pure profit in the practice setting. This is a 3D printer, one like we have at the school called a Sprint Ray. These are the steps that you go through, everybody knows. And look in the bottom right. How much oral bacteria do you think is growing on that lab counter at the end of the day? So here's our iTero scanner with the wand and the view box. And this is what the model looks like when it's scanned. This happened to be a patient who was about to have orthodontic surgery. And below there is the 3D printed model of that same scan. And you can see the scan and the printed models are pretty close to each other. They're very accurate. They're just as accurate as impressions and pouring models. And you can see it captures the teeth very, very well. So I put up, this is the same patient, but I put up 3 different representations of the teeth. The very top is a 3D printed model. In the middle are the right buccal, frontal occlusal, and left buccal views. And on the bottom are the plaster models that were made for this patient. So if you could have the product at the top and save 2 hours of work, which are you going to go for? I'm going to go for the 3D printed models. And again, you can see how accurate they are. The photo, printed model. And one of the advantages of printed models, you can see the yellow wax here. That's where somebody bumped these models and broke the cuss tips off. So before we printed them, we added the material back and just carved it. So this is what our 3D models look like in dolphin imaging. And you can take this and grab and click it and rotate it, spin it around backwards. You can get any view that you want to out of that. Now, one of the nice things that we can do in dolphin with our 3D models is we can make measurements. So this kid is a half-step class 2. And at the end of treatment, we want to see if the mesiopalatal cusp of his upper first molars can fit in the central fossa of the lower first molars. So how can we do that without a hard model or trying to measure something off of a computer screen? Well, if we look on the left, we can go to digitize and measure. And then we take our cursor and we put a little dot in this lower right first molar, which you can see right there. We're going to do the same thing on the other side. And then the computer will actually measure this for us. So it's 47.1 millimeters. We can do the same thing in the upper arch. And you can see it's 46.7 millimeters. So without models, I can tell if I need to do some expansion with my treatment. And there's only 1 millimeter, it's less than a millimeter difference between this measurement and the one in the lower arch. So in this child, I would not do any palatal expansion. I would just derotate the molars, and that's going to give me enough width in the upper arch to fit with the lower, and that's going to be the end of it. So you can figure out some things that you're going to need in treatment well ahead of time, the time to do tooth movements. One of the things, and this is what we make our students do on all of most of the cases and all of the extraction cases, is that in dolphin, there's what's called the MBT philosophy, Visualized Treatment Objective Program. And what it does, it quantifies tooth movements needed to achieve a treatment objective. And it's built around the lower arch. Why? Because we have to build our traditional orthodontic treatment around what we see in the mandible unless surgery is involved. It also takes into consideration moving the lower midline onto the mid-sagittal plane of the face, and it works out pretty well. So this is what it looks like on the computer screen. So you can see this person's a full step class 2. So they have 7 millimeters of correction to do. This is a half step. So it's about a little more than half step. It's about 4.5 millimeters. And the lower midline is off to the patient's right, about 3.5 millimeters. We don't worry much about the upper midline in this because if we get our canines right and our lower incisors positioned correctly, the upper midline should match if we get the upper canines class 1 to the lowers. And there's no tooth size discrepancy. So what we can do is we plug in some values, crowding, curve of SPE. It takes 1 millimeter per side of space to correct 1 millimeter of curve of SPE. And it shows you the tooth movements necessary. So in this case, we would have to back up this canine and this molar 6 millimeters. That's not going to happen in my treatment. We can add some things here. We want to have a class 1 molar. So it shows you what the tooth movements have to be to do that without extractions. You see there's a 0 here and a 0 here, meaning we're not taking any tooth mass out of these quadrants at this point. But if you continue to follow that, maybe we can do some interproximal reduction. So we're gaining about 1.5 millimeters right and left in the incisors. And so these numbers start to change a little bit. So we still have problems on the left side with backing up these teeth. It's easier to make teeth move mesially than it is to make them move distally. So what if we did a 4 bicuspid extraction? Would it make our treatment planning easier? Well, we go to a fresh screen. We add 7 millimeters of extraction space here. And you can see now, if we hold our molar, we'd have to back the canine up about 6 millimeters. On this side, if we extract a tooth, this molar can come forward 8 millimeters. Well, that's not doing anything other than changing molar relationships. So this is probably a bad tooth movement down in the lower left. If we do extractions in the upper arch, all of a sudden these tooth movements become a little bit easier. We don't have to back the teeth up so much. We still have 8 millimeters of protraction of the lower molar on the right side. So let's change things a little bit. And you can see we're not extracting a tooth over here. So that's wonderful because these teeth just need to move mesially about 2.5 millimeters. And on this side, we have reciprocal space closure. Teeth are moving toward each other in the extraction space. Our tooth movement becomes much easier. And you can see up here where all the crowding is. The computer will do this for you. So what we ended up was taking out 1 lower left bicuspid, mainly to move the midline over and to alleviate the crowding. In the upper arch, in the lower right quadrant, we didn't take out a tooth because we have easy tooth movements. In the upper arch, we take out 7 millimeters, which is a bicuspid on either side. And all of a sudden, we have a much easier tooth movement. Reciprocal closure. This is kind of one-way closure. But if we have some good anchorage, we can do that. So it tells me I need to extract the upper left 4 instead of the 5. I need to do some IPR. I need some great anchorage, and we'll have a little bit of compromise in the lower arch. But this is called a visualized treatment objective. It used to be that you had to do it on paper, and now you can do it in Dolphin. What about CBCTs? I would imagine most people have had exposure to them by now. It's the CT technology. CAT scans have been around for a while, but in the last decade, the cost of the machines have come down quite a bit. So most ortho practices in the US and some general dental practices and most oral surgery practices have CBCTs. It's kind of the poor cousin of the CAT scan, but it utilizes a lot less radiation. The panoramic and cephalometric radiographs can be rendered from a full field of view CBCT, and the CBCTs can produce dimensionally accurate images of teeth, bone, and soft tissue that covers the face. At our school, we take full volume CBCTs on patients that have significant facial asymmetry. If they're a surgical case, anytime we suspect a manifestation of a systemic disease in the maxillofacial and the oral complex, if you take a full field of view, you need to have it read by a radiologist. So that increases the cost associated with the treatment. Why? Because as dentists, we're not trained to look at the rest of the head. We're trained to look from kind of the nose down to the bottom of the chin. So if you take a full volume CBCT in the US, generally you have to have a licensed radiologist read it and give you a report to keep yourself out of trouble legally. For our impacted teeth, such as our impacted third molars or an impacted canine or any other, we take kind of a limited field of view. And then you can also make images that are similar to a periapical radiograph with these. So here's the question. This is the upper left canine. Can you determine where it is in this patient's face? Well, it's somewhere in the neighborhood of the central incisor or the lateral incisor, but we don't know if it's facial or if it's on the palate, do we? And this is what it looks like clinically. And this is what it looks like on the ceph, but I still don't know exactly where the tooth is. If we take a CBCT, we can see that it's overlying the root of the lateral incisor. So if we're going to erupt this canine, we probably shouldn't be moving the lateral incisor very much unless we could move it completely distally. All right, can everybody see that? So basically we have a jumble of teeth here. And then we can further take those images and look at the coronal, the axial, and the sagittal slice and get a much better idea of where the tooth is before we start manipulation of the tooth to try and erupt it. And we can just look at axial views that are taken at different levels, and we can see the teeth and the roots and where they are in relationship to each other. So this has been a great help in dealing with impacted teeth. Now, I would hope that you don't take a CBCT on any of your ortho patients and see this. This was done by a practitioner who believes that it's against the rules of nature to remove teeth for orthodontic reasons, so he opens up the space on patients that have had extractions done. And how long do you think these teeth are going to last in this patient's head? Not a very long time. It's really sad. What else do we use the CBCTs for? Well, we use it in orthodontic surgery. So you can see we have our saw guide that's printed here on the right side of this middle one. On this left side, you can see this is a three-piece maxilla. If you could see the other side, you could see there was purple, green, purple, and a mandibular reduction here. These are the screw guides. So they'll put little pilot holes here, 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 and then they can put the complete fixation plate into those holes. So these are fixation plates that can be custom printed as well. So this is what the saw guide looks like, and this is what the fixation is going to look like. And I think you can, let me back up here. These holes where you temporarily screw in the saw guide match up with the holes on the fixation plate. Sorry, I keep hitting that. So you can see there are two holes right here above the cut line. And there are two holes back here where the screws are going to go. We have digital surgical treatment planning now so that we don't have to take face bows and mount the models and cut the models and measure everything and form our splints. We do two different types of digital surgical planning. We do them with the CBCT, and it's usually done with the surgery technician from the imaging company. In the US, it's KLS Martin, and there are a couple of other companies that do it, but that's the one the school used, KLS Martin. The oral surgeon will be there. Sometimes the orthodontist is there, most of the time not, because most orthodontists don't have a good understanding of orthodontic surgery. But you can get the surgery planned, you can have your fixation plates custom printed, you can have your saw guides printed. All this comes with a cost. Now in Dolphin, we can do 2D surgical treatment planning. It's a pretty good representation, but you don't get the 3D volume with that. So let's look at a CBCT-based surgical prediction. Here is a guy that had hemifacial microsomia, and oddly enough, it's on his left-hand side, even though his chin is off to his right. So you can see he has a posterior crossbite, an anterior open bite. It's kind of classed, a little bit class 2 on the canines on one side. Some facial asymmetry, ears, one ear is lower than the other. Here was his panorex. And you can see some of the asymmetry of the body of the mandible. It's much more diminished over here than it is here. And here's his ramus on the right side, but over here he has a much diminished coronoid process and ramus, as well as the whole ramus is diminished. And here's this traditional ceph. You can see the open bite and a class 3 tendency. The first thing we did, we lengthened his left ramus, and this is a osteogenic distractor screw that comes out in his left angle of the mandible. You can see it in place, and as he turns this, they made a surgical cut right here. As he turns this elongates, and it pushes this portion more inferiorly. And this is what it looks like in place to lengthen that left side. And that's what it looks like when you buy the kit. So you get these bone screws and the holder, and this is the moving part right here. So there he was, and now he's got a maxillary expander in. He had what's called a SARPE, a surgically assisted rapid palatal expansion. So he expanded the upper arch, and you can see the difference between the right side and the left side. And then this is what a 3D surgical treatment plan looks like. Typically, the upper arch is operated first in the United States using the lower arch for the provisional splint right here. And some surgeons in the US will do the mandible first, but most surgeons will do the maxilla first. And now that asymmetry is really apparent, isn't it? So we're going to operate the upper jaw and level out. This is called roll. One side's lower than the other, and you see it's been leveled off. And then there's going to be a splint that holds the upper jaw in place while they put the plates in. And these treatment plans tell you the movements. Almost 3 millimeters down at the at the lingual cusp of the upper left first molar, and up on the other side to get the cant out. Tells you anterior posterior movements that you have to do. So now we've got the maxilla in place, and then it makes a second final splint here. And so now the mandible is going to be operated with a vertical ramus osteotomy on this side. Everybody can see that. So they can change the vertical dimension. And they've also added a genioplasty to move his chin point a little bit. And one of the beauties of this is they can see exactly where the inferior alveolar nerve is running through the canal and where it exits out here. So this is real important because you have to be careful when you make this cut for the genioplasty. You have to be careful that you don't cut the mental nerve down there. And it will tell you how far away the distance objects are from the inferior alveolar canal. So that's just showing us where the molars need to move in the lower arch. So here was his final set of photographs. He's not perfect, but he looks a lot better than he did. And with these cases, sometimes perfection is the enemy of doing good work. Here's his fixation in plate with the screws. And now these patients are not wired together for 6 to 8 weeks like they used to be when I was trained in this. They're rubber banded together for about 2 weeks, and then they're asked to function using their jaws to eat, and they can come off of their soft diet. And it works out pretty well for the patient. So here's his before and after. I'm going to show you a lady that we operated using, I did a dolphin surgical plan just to see how close I could get to the actual result. But you can see she's class 3 with a little lower incisor crowding. Pretty good upper arch, but you can see the crowding here. And one of the things we have to remember in oral surgery with orthodontics, if the jaw is going backwards, moving posteriorly, the lower incisors should be moving forward. But we can look at all this in dolphin. Here's her pan. There's herself, and you can see the negative overjet here. So I'm going to do a 2D surgical prediction for her. And we're going to put our self-tracing and match it up to the cephalometric image. And then we can start moving teeth around over here. So I've proclined, if you look carefully, you can see this red incisal tip is a little bit anterior to where the tooth actually is. So I'm going to procline those teeth forward. Our upper dentition is going to pretty much stay home. She didn't have much crowding. And now I've advanced the maxilla forward about 5 millimeters. You can see the incisal edge out to this incisal edge. And you can see here that we've moved the upper jaw forward about 5 millimeters and a vertical change of about 1 millimeter. And now we need to go back and do the mandibular reduction to give her positive overjet here. Let me back up here. You can see it there. And then I've added the genioplasty down here. And so that's the 2D surgical treatment plan. It's kind of like we used to do. Regardless, this is how she turned out. The treatment planning was easy. The orthodontics was easy. I didn't have to do the surgery. It may have been more difficult. But nonetheless, we get a very, very nice result with computerized treatment planning. And it's a lot less work than it used to be, believe me. So there we go. There's her fixation. And you can see the genioplasty plate down here. Right down here. And here's her cephalometric tracing after she had her surgery done. So we can compare numbers and see what actually happened. And this is what I predicted with the 2D, and this is what she turned out like. So she actually looks better than what I predicted. So that's always a good thing. And there you go. I'm going to show you another use of technology. Now, I'm going to confess, this is the first patient I've ever participated with that had this done. This is another surgical patient from Augusta University. So you can see she has an anterior open bite. And if you look a little more closely, we're going to look at the left photograph, the non-smiling. I'm going to make a line that connects the inferior, the inferior eyelid. You can see some sclera beneath the iris. So that means she's maxillary deficient, and she has what we call roll. She has a vertical asymmetry. Let's look at the top of her ears. And you can see that they're not parallel. And then let's look at the bottom of her ears, at the tragus. Can everybody see this patient is not symmetrical? Solar, is that apparent?
Yeah. Sure.
Okay.
Yeah.
So the reason she's not symmetrical, and I'll show you her x-ray in just a second, and it will make sense then. Here's her dentition, which just looks like she had upper bicuspids out, orthodontic treatment, some relapse, her bite opened. Let's look at what's going on with her mandible. Does one side look different than the other?
Yes, that's apparent.
She has a mild case of hemifacial microsomia, just like the previous surgical patient, the first one I showed you, does. And so we needed to fill out her face a little bit in the posterior. So we printed her skull as well as her mandible and had a prosthetic piece of mandible made, was 3D printed. And see how it fits here? And that's going to be attached to the ramus in the inferior border of the mandible on the right side to fill out that tissue just a little bit. And so that's the 3D rendering of the prosthesis in place. It's not going to be perfectly symmetrical, but it will be better. And you can kind of see the asymmetry a little better with this coronal view of her facial skeleton. So we had a definitive surgical plan formulated. And when you have these treatment plans done, you cannot move the teeth after that because they print the splint based on what you sent them. If you move the teeth following the building of the splint, it won't fit. And operating room time in the United States is very expensive. So here was our genioplasty predicted movement as well, about 2 millimeters to the left and about 4 millimeters anterior. Here are the 3D printed saw guides for the genioplasty as well as for placement of the pilot holes. And once she had her surgery done, this is the plate that they custom bent to help hold this prosthesis in. You cannot see the prosthesis because it's not radiopaque, but it's in there. And the surgeon told me this was a tough surgery to get it placed in place. But you can see her before and after. We closed her open bite. I was a little bit disappointed. She's still kind of long in the face, in the lower anterior face. But she looks better. She's happy. And we had her braces on for about a month after her surgery. We took all the appliances off and finished her up with Invisalign. So we had 3D printing, 3D surgical treatment planning, 3D imaging, and Invisalign as the last piece of technology that was placed into the mix. Do you guys use a diode laser? I'm not sure what's available. This is the one we use at the Georgia School of Orthodontics. This is a Gemini laser. It has dual wavelengths between 810 nanometers and 980 nanometers. And it's very effective at cutting soft tissue. And this is very high tech. It actually talks to you when you turn the machine on. And it will talk to you during the operation of the machine. Here's a group at the Medical University of South Carolina testing the Gemini against the Easy Lays by BioLays. All these students that you can see here in that left picture love the Gemini. So what can you do with a dialed laser? This is a nice ortho result, but aesthetically, the anteriors aren't great. The centrals look a little too short for their width. So we went in there with a dialed laser, did a gingivectomy / gingivoplasty. And here she was 10 days after the surgery. So a dialed laser for you orthodontists out there can make your good results look even better. Here's the facial canine exposure with a dialed laser. You can see the tooth just begging to be exposed here. It just wouldn't come through. We exposed it with the laser. We left a solid 2.5 millimeters of attached tissue. And 3 months later, the tooth is down into the arch. Here's another gingivectomy. You can see one canine is longer than the other. The lateral incisors don't match. This one's a little too short relative to the central incisor. So we debonded her, did a gingivectomy, and here she was 10 days later. So it made a huge difference. You know, if you look at the details of the case, it makes a huge difference if you have a laser available. Facial canine exposure. This is on an adult, and you can see these two canines are parked right here over the laterals. Notice we do not have the lateral incisors attached to an arch wire because we want to move these teeth before we want to move the canines before we do the laterals. And here she was in October. Here she was the following June. So a diode laser, and here she was about, a little bit later. So the canines are down in the arch, and now we're just finishing up the case. You can expose canines on the palate. You can see these two guys up here just begging to be exposed. Again, we take a CBCT to see if there's bone over the crowns because the laser will not cut the bone. It will only cut soft tissue. Here's the first exposure. Here's the second exposure here. And then we cemented our transpalatal arch with some little hooks as an anchor unit to pull these canines in. So as an orthodontist with technology, we can do some oral surgical procedures. We started having to do some virtual visits at GSO during the COVID pandemic. And a lot of times we'll do our initial screening visit with a virtual platform now. So we use a company called DoxyMe. In the US, it has to be what's called HIPAA compliant. But DoxyMe allows your patients to communicate with you. There's no ability to get protected information of the patient off of here. You don't have to download any software. It works on Chrome, Firefox, and Safari. And you can do text and email notifications about appointments. They can make payments. You can transfer data within there. You can share the screen. Or if you need to have like a treatment conference with a couple of parents and a child, you can do a group meeting. It's encrypted from peer to peer in audio and video, so nobody else can, hack into it while you're doing a conference. Patients are anonymous. We don't collect any protected health information. There's no data that's stored. What else do we have for remote visits? This is from a company called Dental Monitoring. It holds your cell phone, and the patient slides the cell phone from side to side while it's making a video. And that video is transmitted to the practitioner via a HIPAA protected platform. And so you can check on your patients without actually having them come into your office. This is kind of what it looks like. There's a company called Mouthwatch that makes an inexpensive intraoral camera device that your patients can use. We've experimented with it. I wasn't very pleased with the quality of the images, but that was just mine. This is a much more expensive intraoral wand type camera. It's autofocus. It does very detailed pictures. The problem is it doesn't have enough field of view for orthodontics. So you can see these pictures are almost like having the patient sitting in front of you in the chair. And here's the problem. You can't get a complete occlusal picture, so you have to take two pictures and kind of slice them together. Same thing in the lower arch. But the detail of the photographs is, I think it's very, very good. I'll tell you a little bit about our school, and we're almost wrapped up right on time. This is our school. It's in this building. We don't have, the ortho residency does not occupy the whole building. We occupy 3 floors. This is our clinic in Sandy Springs, north of Atlanta. This is that same clinic from another view. There are 3 6-bay chairs, and then there are about 10 other chairs for other reasons, for banding, bonding, etc. This is our classroom. We just built some new classrooms, and I haven't been in them yet. So these just came online this past month, and I'll go back to Georgia, to Atlanta next in July. We can divide our classrooms. We can also, you can see here, there's a small classroom. So we were broadcasting lectures well before COVID because our other clinic is about a 30-minute drive from this clinic. And here's the waiting room at our Gwinnett clinic. And here's what our clinic area looks like. So it's, we use a lot of technology. Every chair has a computer screen. We use Dolphin imaging, Dolphin software. We have a diode laser in each location. We have a CBCT machine in each location. So we're pretty well decked out for high-tech orthodontics moving into the 21st century at the Georgia School of Orthodontics. Is this all of the technology? No, we'd have to have a weekend to cover everything. But it's some of the things that I've felt have made an impact on the practice of orthodontics. So I'm going to stop here, and I think someone else is going to take over the question and answer.
Thank you very much, Dr. Harrell, for your informative lecture. I enjoyed a lot. I really appreciated you shared your experience as expertise with us in terms of cutting-edge technologies in orthodontics. Actually, I myself loved the part about the Damon appliances, because nowadays in my country, there's lots of advertisements around there, and patients come and ask for Damon appliance. They think that there would be a miraculous action, being unaware of all the disadvantages. So thank you for informing us. Now I would like to ask our dear audiences for the questions. So dear audiences, anyone with the questions, you can raise up your hand, and the admins will turn on your microphone. Salar, are you there for helping me?
The alarm must have fallen asleep.
Okay, dear audiences, any questions? If you're writing your questions, maybe I want to ask my question. You know, Dr. Harrell, I have a question about the legal aspects of these remote visits. You know, I have a very pleasant experience about this remote visiting, and it dates back to about 6 years ago. I had a patient in Tehran University Special Clinic. She was a PhD student, and suddenly, in the middle of treatment, her application for a course in Switzerland was accepted, and she had to leave Iran for 6-8 months. And we were on 1925 steel wire. We wanted to start anterior retraction in upper arch. She was a class 2D1 patient with a lot of overjet, needed absolute anchorage. So I inserted the mini screws, gave her a lot of pieces of chains, and showed her how to change the chains, and asked her to take photos, and every 4 weeks send me the photos via WhatsApp uplines. And every time I used to check the photos, and everything was going very well. And finally, when she came back, the space was closed very well, and everything was okay, just like a patient who comes in present. But, you know, when the things go well, nothing happens. But, you know, when the chips go down, then the problems rise up. I want to know about the legal aspects of this type of visiting.
In the United States, and I don't know that there's a case that's been tried in a courtroom setting yet. If your patient lives out of the state in which you are licensed, that can be considered practicing without a license in the state where the patient is residing. If the patient, let's say the patient lives in Atlanta, like your patient lives where the school is, and they go out of state, state boards generally will allow you to practice across the state line remotely if the patient is a resident of the state in which you are licensed. I don't know that we've had a case that has been litigated yet where the patient or the State Board of Dentistry sued the orthodontist for practicing, you know, with say a Georgia license in the state of North Carolina. So I don't know exactly all the legal ramifications. Most of ours, we had one patient who had moved, and we did a couple of remote visits just to check his retainer, and that was it. We haven't done a lot across state lines just yet. So that's something that will be determined in the future as this technology becomes more and more accepted and utilized by the orthodontic practitioners here. So I don't have a great definitive answer for you on that one.
Thank you very much. Dr. Moshara Abdi has also a question. Dr. Abdi, I'm trying to unmute your microphone. I pressed the button of ask to unmute, so you have to approve it. I think now you should approve it.
Hello, can you hear me?
Yes.
Hello, Dr. Abdi. Yes, we can hear you clearly.
What is your question?
Yes, Dr. Abdi, we are at your service. I think he's again mute. Dr. Abdi, I unmuted now. I think your microphone is on. Please ask your question.
Thank you.
Yeah.
My question is about in-house aligners. Have you ever considered to use the in-house aligner instead of Invisalign, Spark, or the other companies?
Yes, we have. You have to remember at the Georgia School of Orthodontics, we have 135 orthodontic residents. to try and print on that scale, we would almost have to build our own aligner laboratory and hire a bunch of technicians. The reason we haven't swapped is that Align Technology, which is Invisalign in the United States, gives our school 400 free cases every year. So we don't really have to pay anything right now to have our aligners made. So we haven't ventured into that. As far as 3D printing, we've basically limited it to 3D printing of models as needed. The students are exposed to it, but most of the private practices that are printing their own aligners have had to hire a technician to come in and do that in their office, which again adds to the expense of producing it in your own office. So there are a number of offices in the United States, especially if the practitioner is very engaged in technology, that yes, do print their own aligners. But the economy of scale with somebody like Align or Spark or any of the other ones is just so much. It's hard to do it on your own and it not cost you more to do it in your own office because it takes up so much time to do these things. Did that answer your question?
Dr. Abdi, can you hear us? I think Dr. Abdi's microphone is off. So Dr. Alireza Jafari also has a question. Dr. Jafari, I unmuted your microphone.
Hi, thank you very much. Thank you, sir.
Hi, Dr. Jafari. Good night.
Can you hear me?
Yes, you're good.
Yes, yes.
Okay.
Yes, we have your voice.
Yeah, I want to thank the sir. It was an excellent presentation. Thank you very much. You cover up all the aspects of orthodontics, and it was great. I just have a question about that young lady where she had a asymmetry and her eyeballs were not in the same level.
Yes.
I think, and apart from that, the another young adult patient where you had distraction osteogenesis for his ramus, and then so many surgical procedures.
Yes.
Do you think we should go ahead with so many procedures? I mean, I don't know how much the patient must have paid for the so many surgical procedures and so many things, you know. Maybe sometime you can do some small cosmetic surgeries and avoid changing so many things in their faces, you know. Sometimes you want to correct a mandible, you get something wrong with the nose, you want to push the maxilla behind, the nose becomes wide.
Yes.
So many complications can happen. I want to know what's your comment. Thank you very much.
You're welcome. That patient was treated at a university setting. So those patients are going to get more treatment, most likely, than in a private setting. The other thing, in the United States, there is a program called Medicaid. And Medicaid pays for the treatment for children with cleft lip, cleft palate, cleidocranial dysplasia, hemifacial microsomia, Pierre-Robin syndrome, Sjorgen, you know, they cover a lot of that. So the cost, if you just look at the cost, it was probably minimal to the patient because the taxpayers paid for it. Now, if I were that, you know, doing that in a private practice setting, I may have done something to try and extend the ramus a little bit, and then done everything like a 3-piece maxilla or a 2-piece maxilla to get the width and not done the Sarpy. probably would have had to have done the mandibular reduction and then the chin. So it would have been one orthodontic surgical experience and one osteogenic distraction experience with an orthodontic overlay. But yes, it was, I noticed when this was going on, there were a lot of surgeons that wanted to get involved with it, you know. And of course, they want the cases for their residents to learn, you know, about the surgical procedures. So that's how it ended up. I think it was 5 surgeries. You know, 2 were preceding the actual orthodontic surgery. And a lot of patients just won't tolerate that. It's just too much for them. So yes, patients that aren't covered by Medicaid, sometimes our treatment plan is simplified a little bit where they don't have so many procedures. But yes, you're very astute, very sharp for picking up on, gee, they had this, they had this, they had this, and they had that. You know, and he was a pretty good sport about it. He didn't like the way he looked, and you know, I think he looked better. Needs a new hairdo, but other he looked okay.
Yeah, right. Thank you very much. Thank you a lot. Thanks a lot.
You're very, very welcome. Other questions?
Excuse
Thank
me.
you, Dr.
Hello.
Jafari.
Thank you.
Hello.
Thank you,
Hello.
madam.
I'm sorry. I'm sorry that I changed my device and I lost my access to my mic. Can I ask a
No
question
problem,
from
sir.
Professor Harrell?
Yes, sir.
Thank you. Thank you. I just wanted to ask your idea about the role of AI in the orthodontics. For example, can we trust AI to predict the results of our treatments, and how much can we trust to AI, or it's soon to trust completely to AI?
Well, if you think about it, whatever you're feeding into the AI is the same information that you're feeding into your treatment planning programs. And yeah. I don't know that I think there's more consistency in the predictions when you do it with artificial intelligence based on, you know, data that's collected from hundreds of cases. Do I think it's going to tell you exactly how the patients are going to end up? I don't. There's too much variation in patient responses. You know, if you had 10 patients and you did the same thing to all 10 of them, maybe 7 of them would turn out exactly the same, and 3 of them would be slightly different. You know, those are the further out than the 1 standard deviation. I think it's going to be a great tool for us, but I think it's a mistake to leave out the human element and expertise and experience and just depend completely on some artificial intelligence program to tell you what to do, whether it be surgically, orthodontically, both, crown and bridge, endo, whatever. I think if we depend completely on artificial intelligence, we're headed for trouble. We will get into some situations that we could have avoided if we had put some human energy into the system.
Yeah, thank you. Thank you. At the end, I want to extend my appreciation to you, dear Professor Harrell, and to Professor Arab for this brilliant session, and I enjoyed it very well.
Well, very good. You know, down the road, if you need somebody else in orthodontics to talk about, if you need other topics covered, Salar, you know where to find me.
Yeah, sure. As always, thank you.
I think Dr. Jafari Naimi has also another question. I'm turning your microphone on, Dr. Jafari. Dr. Jafari, your video is on, but you still haven't.
Can you hear me now?
Yes, sir.
Yes.
Yeah, I'm sorry for asking so many questions.
That's okay.
It's on my mind. I wanted to ask about this MBT video. How often have you used it and how accurate it is? How much it has helped you out? You spoke about it and it was very nice. You showed us one case. But do you use it often? How often you use it in your clinic or in the university? Can you tell us something more about it?
In our school setting,
Yes.
they have to use it on every extraction case.
Okay.
For a non-extraction case, it's kind of optional. But what the VTO does, it gives you a pretty good idea of your tooth movements. And I assume you're an orthodontist, sir.
Yes, yes, I'm an orthodontist.
Based on your questions, I assume you're an orthodontist. We know that, if you can see my fingers, we know that reciprocal space closure is much easier than unidirectional space closure and the subsequent loss of anchorage. So it gives you a great idea about what kind of anchorage you're going to need, whether you should extract a first bicuspid or a second bicuspid, or let's say the patient is a full step class 2 and is a 14-year-old female, whether or not you should extract a lower bicuspid on the full step class 2 side at all. Because I base my treatment planning on where the canines are going to end up. You know, and if we get the lower canines in a good positions, our upper one matches, we have our 6 anteriors, that's all settled. I don't care as much about if it's a class 1 or class 2 or a class 3 molar relationship if we have to extract the tooth in the lower arch in that quadrant. But mainly it pounds this idea in that 4 first bicuspids in an extraction case is not always the best treatment. In fact, many times it makes your life miserable. So it shows, let's say we needed to lose 5 millimeters of anchorage in the lower arch where we're going to do an extraction on the one side. I'd probably take out a second bicuspid as opposed to a first bicuspid because it's easier to burn the anchorage that way. So I'm a believer in it, especially for young students who have a difficult time visualizing tooth movements. And if I were in private practice, would I be using it on every case? No. You know, I've treated 10, 12,000 cases now. I can look at it and say, okay, this is probably what we're going to need to do. Let's verify this with imaging and some other things. But for a young student coming into the world of extractions in orthodontics, I think it is a wonderful tool. And we used to have to do it on paper. And then Dr. McLaughlin, who is retired now, he helped develop the computerized program so the students can actually see the teeth move, you know, the representation of the tooth on the screen. They can see it, so it goes, oh, yes. Now, if I have to back this tooth up 7 millimeters, I have to have an anchor back here, you know, or this tooth's going to come forward 3 millimeters while this one comes back. So it gives them a good idea about anchorage, a good idea whether extractions are indicated, and it kind of it doesn't tell you, but it kind of leads you in the direction of what tooth you should extract. And
Thank you very much.
I love playing around with it. The hard one is when you do one lower incisor extraction, your midline obviously is off.
Yes.
So that's a harder prediction to do, but you can do it.
Yes, sir.
I have about 5 lectures on VTOs with patients to show how they make a difference in treatment, but I'm a firm believer in them.
Thank you, sir. Thank you very much. Thank you very much for your detailed explanation of the system and how it works. And for your information, all those who are in this group, those who are present in this presentation, all of them are orthodontists, or they are either they are resident, they are postgraduate students in orthodontics, or they are experienced orthodontists. Thank you very much once again.
Yeah, thank you. Sometimes when I speak to general dentist and orthodontist, I really have to tone it down a little bit, you know, because we speak our own language, basically.
Thank you, sir. Thank you.
You're very welcome.
So I think there is no other questions left. So Dr. Harrell, once again, on behalf of the International Deputy of Tehran University, I would like to express our deep sense of gratitude for your presence, your informative lecture, and in addition to all of that, your kind and humble vibes. Solar and I will keep in touch with you. So we hope that we can use your lectures and your presence in future. Anything else you want to share with us?
Well, I hope you can see I love to teach orthodontics. I'm passionate about it. I've been doing it longer than many of your audience has probably been alive, you know, from 1984 until the present. And it's been a wonderful career, and I have no regrets about going into orthodontics. And I hope all of you are experiencing the same thing, that it's a wonderful profession and we can make a difference in children's and adults' lives. One of the things I would offer is I'm hooked up. I am part of a cleft palate team, and we go to Bolivia to operate on kids down there. They don't have access to a lot of our care. I'm getting some wonderful teaching material. So, you know, next year, if you want something on cleft palates and lip surgeries and palate closures, I've got the goods for you.
Thank you very much. Thank you very much, Dr. Harrell. We look forward to seeing you soon in next lectures. Okay. And I wish you a perfect day.
Thank you. Take care, guys. Bye-bye.
Goodbye, everybody.